How is everybody?
Hanging in there. How are you?
Oh, hanging in there.
We're live and ready to go, Senator Kelly.
Okay. Good afternoon, everybody. The Senate Finance Committee is now in session, and we are here this afternoon to get a very much needed briefing on Medicaid, and we're especially interested in what the department has asked for with the increased rates and why we haven't had the opportunity for providers and caregivers in Maryland to participate in determining what it was that would be the ask. And so we're this afternoon looking forward to hearing from the Deputy Secretary, Steve Hsu, and Heather Scheck, Director of Governmental Affairs. And you guys can take it away in whichever order you'd like to go.
Members of the committee.
Oh, go ahead.
Okay.
You were muted.
Sorry, we were muted. Good afternoon, Chair Kelly, Vice Chair Feldman, and members of the committee. Delighted to be here with you this afternoon. For the record, my name is Steve Hsu. I'm Deputy Secretary for Healthcare Financing and Medicaid at the Maryland Department of Health, and I'm the State Medicaid Director. Next slide, please. There are now 1.6 million people in the Maryland Medicaid program, or about 25% of the state of Maryland. Our annual budget is approaching, our annual Medicaid spend, not the MMA budget, is approaching $15 billion, of which a little over 39% is state funds. Next, please. As I think you know, we have 9 managed care organizations, or MCOs, operating in the state and administering health benefits to approximately 86% of Medicaid beneficiaries. Next. Turning to our 9 most important priorities, I'll take you briefly through each of these. Next. Our most important immediate priority is, unsurprisingly, the ongoing response to the COVID-19 pandemic and the challenges it has and continues to present. To that end, we have made telehealth an integral part of many of our programs. We are utilizing $517 million in enhanced federal matching funds to support our somatic health, behavioral health, and disability services providers, and to maintain coverage of all Medicaid enrollees without interruption. Our policy is generally not to disenroll any participant during the pandemic. We've also taken various actions to extend many COVID-related flexibilities to support our providers. Next. Since the beginning of the pandemic, Medicaid enrollment has increased from 1.4 million to over 1.6 million, an increase of 212,000 participants, reflecting both the impact of COVID and our policies toward disenrollment. Next. The department and our MCO partners are taking numerous proactive steps to address the COVID challenge. MMA is introducing a $5 million incentive program that is tied to achieving specific vaccine targets. The MCOs themselves are pursuing various educational initiatives, collaborating with the Vaccine Equity Task Force, hosting vaccine clinics, and engaging in aggressive outreach to unvaccinated participants through TV, social media, text, phone, and email. MDH and the MCOs have a weekly cadence call to collaborate and to discuss unique ways to reach participants. Next. Our next priority is the total cost of care. The purpose of the total cost of care model is to contain healthcare costs while improving quality. There are many initiatives underway that are under the umbrella of the total cost of care, but 2 warrant particular mention: the State Integrated Health Improvement Strategy, or SIHIS, and the Maryland Primary Care Program, or MDPCP. Through SIHIS, the department is putting special focus on people suffering from opioid use disorder and from diabetes, and on low-income expectant mothers and young children. With respect to MDPCP, we're working with our federal partners to bring Medicaid into the program as a participating payer. Next, enhancing the state's Medicaid Management Information System, or MMIS, is another major priority for MMA. MMIS is the core IT system supporting all Medicaid operations, including claims processing, member and provider management, and reporting. Traditionally, MMIS has been one large monolithic system. The new system will be modular with greater interoperability and data sharing. There will be enterprise architecture at the project level and a focus on Medicaid IT architecture maturity gains, particularly increased customer service and program integrity. The entire transformation is anticipated to take approximately 10 years. Next slide, please. The American Rescue Plan Act, or ARPA, provides states with additional 10% federal matching rates on home and community-based services between April 1 of 2021 and March 31 of 2022. ARPA requires states to reinvest these additional federal matching dollars back into the programs. The Maryland Department of Health, MDH, has until March 31st, 2024 to complete the reinvestment requirement. The Maryland State Legislature was proactive and passed budgetary language requiring us to spend 75% of the reinvestment dollars in a one-time rate increase. Maryland held its stakeholder process during the session on 75% of the reinvestment requirement. Although the budgetary language was specific to developmental disabilities and long-term care services, MDH has committed to honoring the same requirement for community behavioral health services. Next, please. Our next priority is renewal of our Section 1115 HealthChoice waiver. Under this waiver, the federal government has granted Maryland special authority to pursue innovative programs, including our adult dental pilot and diabetes programs, among several others. We're also working through the renewal process to modify various existing programs so as to increase benefits and to expand eligibility. Next. Finally, we are seeking the authority to provide reimbursement for adults with serious mental illness who need to be in an institution, expand the maternal opioid misuse, or MOM program, and establish the Emergency Triage, Treat, and Transport, or ET3 program. Next, please. Our next priority is setting new rates for the managed care organizations for calendar 2022. We have included for the third year the concept of risk corridors to better manage risk and a one-time mid-year acuity adjustment. Separately, we are reaching the end of the rate study for providers working with the developmentally disabled community. We expect this effort will be completed by this winter. Next. As you know only too well, we and the behavioral health community have faced tremendous challenges resulting from United Health Group Optum's inability to meet its contractual obligations to provide administrative services to our behavioral health program. UHG Optum's initial inability to pay claims during early 2020 resulted in approximately 6 months of having to make estimated payments to providers based on their historical revenue experience rather than on their actual claims submitted. The estimated payments ended in August of last year. And since that time, UHG Optum has been successfully paying the vast majority of claims in real time and within industry standard turnaround times. An artifact of the estimated claims period is that due to low utilization during COVID, providers have been overpaid by approximately $237 million. Next, please. Better integration of somatic health programming and behavioral health programming is another very high priority for MMA. This effort commenced in 2019, but was interrupted by the pandemic. I am pleased to report that this initiative has been reactivated as of this past spring. Next, our final priority, but among the most important for MMA, is advancing health equity, particularly through the newly established Maryland Commission on Health Equity. The commission is mandated by the Shirley Nathan Pulliam Health Equity Act of 2021, which becomes effective on October 1st. The mission of this commission is to employ a health equity framework to inform decision-making processes throughout state government, advise state and local leaders on issues related to health disparities, and set goals for health equity. That concludes my remarks, Madam Chair, so I will turn it back to you. Thank you again for having me.
Thank you. Are there questions from any of our members or comments? Okay, I see none at this time. So we'll move on to hear from the Director of Governmental Affairs, Heather Shack.
Oh, thank you, Chair Kelly. I'm just here as in the capacity to answer any questions that the committee may have. I think Mr. Shu's presentation covered the topics that we were asked to present on.
Okay. Well, in that case, let me just start with a question. I guess I mentioned it initially as we were introducing you guys, and that is the great concern expressed by our providers regarding the department's submission of a plan as to how to use the increased rates that we got without having consulted at all with the provider community. What can you tell us about that?
Yeah, I'm
noticed
surprised
that Maryland was the first one out of the gate submitting a plan to the feds, but we hadn't talked to the folks at home. Okay.
Yeah, Madam Chair, I'm a little surprised that you're getting that feedback, because I do feel like we have been engaging the provider community certainly during the legislative session and since. For example, with the developmental disabilities providers, we meet with their representatives, the DD Coalition, the Development Disabilities Coalition, weekly. And we've walked them through every step of the process and received an enormous amount of input from them. I think they're actually very satisfied with the level of input that they had, and they have indicated that they are pleased with the plan we've put forward with CMS, with the Centers for Medicare and Medicaid Services at the federal government. But if there are people who are approaching you and feel dissatisfied with the level of communication, by all means, please forward those communications to me and we will reach out. We want to make sure that our providers are well informed. We value them as critical partners.
Okay, are there other questions or comments? Okay, hearing none, I guess you have satisfied the information needs of the committee for now, and I will be getting back to you because I am hearing from a number of our very important providers who have great concerns that they did not have input that you submitted plan to the feds as to how the funds would be divvied up when we were getting a rate increase, and they weren't talked to at all.
Kelly?
Thank you for that.
Okay. Yes, Senator Augustine.
Thank you, Chair. It's more of, first of all, thank you to the team from Medicaid for presenting to us. I appreciate that. One of the things that I felt like I didn't hear across the last 2 days of presentations was really talk about sort of the health outcomes that we have seen and where we stand with regard to health outcomes. We obviously talked a lot, and I understand about the costs, but I am also very interested and concerned about how we're doing with regard to health outcomes in obviously in this current environment with regard to COVID, but then also just in general. You know, we're paying attention to the money, but how are we also doing on our health outcomes?
Senator, thank you for your question. We are very vigilant with respect to health outcomes and monitor them constantly in innumerable areas. And there are a number of concerns that are, I think, probably very familiar to you. There was a great deal of underutilization of healthcare services during the more intensive phases of the pandemic. The consequence of that is obviously deferring what could be very important medical procedures for people. This takes time to see in statistics. But fortunately, we are seeing, after a period of great pressure on the hospital system in terms of census, significant and sustained declines now in the COVID census that has brought the overall census level of Maryland hospitals down to much more manageable levels. So there's no reason related to hospital capacity that should lead any citizen to defer an important medical procedure at this point. Another area of particular concern to me as the former executive director of the Opioid Operational Command Center is how COVID has accelerated what was already a public health crisis in the area of substance use disorder. Fatalities did increase significantly during 2020 as a consequence of COVID because people were disconnected from their support systems. They couldn't get to counseling. They were stuck at home. There was despair, job loss, all of the witch's brew of factors that lead people to misuse substances. And unfortunately, with the prevalence of fentanyl, which is in effect a synthetic opioid comparable to heroin, but much more powerful, 50 to 100 times more powerful, the consequences of overdose today are far worse than they have ever been in the history of this state or this country.
I completely agree, and we're here to work with you on mitigating that as best possible. So thank you for that.
So important that we work together on that.
Thank you, Madam Chair.
Okay. Are there other questions or comments? Okay, well, thanks so much, everybody, for being here. And if you have further questions, I'm sure the department reps are interested in hearing. And everybody have a good day.
You too.
Thank you very much.
Bye.